This is a presentation about how to check skin. And I'm Marcia Stickle, a nurse for the Wasteman Wellness Inclusion Nursing Program, commonly called a WIN nurse. So we work with individuals in the community who have intellectual and developmental disabilities, as well as health issues that require extra support and consultation. In our work, we've seen many individuals struggle with skin issues that then develop into big problems and infections. Individuals may be unable to explain or understand a skin problem and show it to others. Often staff have not been checking the client's skin and they then don't find the challenges. We developed this webinar to help you understand the importance of skin checks and what to do with what you see. Skin protects the inner workings of the body. And you're going to hear this over and over. The skin is the largest organ of the body, measuring about 20 square feet in total. Skin protects the inside of our body from infection. It helps regulate body temperature, and it helps us feel touch, heat, and cold. When the skin is broken or irritated, it increases the risks for further health challenges, and it hurts. So check skin daily, and you see some pictures of some of the things that you may find, from pressure ulcers to yeast to shearing to skin tears to rashes, boils, self-injury, and picking. Have you seen any of these, or have you experienced one? I strongly encourage documenting what you see. First, check the body, and then document what you see. This body map is available on the WIN site, so you can make copies for yourself. A body map allows you to put exactly where on the body you found something, whether it's a rash, an open spot, a boil, whatever you see. This can help multiple caregivers keep track and monitor skin changes. If people are diligent about doing this, we can track, things can be tracked and things can be taken care of. So doing daily skin checks, paying attention to high-risk areas, and then looking at them and documenting them and taking action. So we'll talk more about high-risk areas as we go on. Basically, it's very important to look for red areas. Red should be a red flag. Look for bumps, blisters, sores, craters, and then record the descriptions and then monitor. Check in areas where a person may have had pressure when you take off the clothing or take them out of a wheelchair, they're transferred out of bed. Those are all times to check as well if you have an opportunity. But for sure, when a person is unclothed because of changing clothes or because of a shower or bath, take that opportunity. Check in areas you might not typically look at too closely, such as in the perineal area, in the buttocks, the vaginal area, the area where a person may urinate. And because when you have any fecal or urine on skin, it really can break down. It also means that those areas are likely to get sweat. So those areas do need to be checked. And an area that I see gets missed a lot is skin folds. So we'll go into that more, but if a person has skin folds, you need to open those up, like take the hands and open them to see what's there, because those often get missed. What do you do if you find something suspicious? If a person lives in a residential setting, you want to contact your home manager or on-call supervisor, whatever the plan is for something that you see that shouldn't be there. For families, you should have a plan of what you need to do, and part of what we'll do as we discuss skin issues is discussing when it needs to be seen by a healthcare professional. If a person's had the same skin issue previously, follow the protocol or plan and use PRN medications as ordered. And as I just said, you may need to have the client seen by a healthcare professional. On these slides, I just say an NP or an MD. There may be somebody else like a wound care specialist. There may be a PA as well who could be looking at the skin. Do not ignore redness or an open area. That is probably the most important thing in this whole presentation. And red skin is a red flag. Action is required. That is the take-home message for everyone who's working with somebody who may have skin challenges, and basically, that could be any of us. What are the risk factors? Advanced age. Now, that's something that happens to all of us if we live long enough, right? As a person gets older, they often have fragile skin, which you see as the fourth point on this slide. But a person can have fragile skin even if they're not at an advanced age. An inability to feel pain or inability to express pain, and confusion. So a person might be unable to feel pain for several reasons: neuropathy, which is often caused by diabetes, cerebral palsy or paralysis, and a person may be unable to say she has pain because she is not verbal or because she doesn't know how to express it. This is a fancy slide with some terms that may be a little bit off-putting for some. So we'll just go through it. It does really help to kind of quantify and clarify how problems can develop. There's extrinsic factors, which means those that are outside the body, and intrinsic factors, things that are internal. And as you can see, some of these terms are very familiar to you, but one you might not be understanding too well is this excessive uniaxial pressure, which is on the left there. A fancy term for meaning not being able to move, so you have a lot of pressure in one spot. And that makes more sense. I think most of us could understand that. We'll talk more about pressure later. So all of these things on left and right, on the left, those things that are outside, friction or shear forces, impact injury, that may be something you would understand, like a car accident or something heavy falling on a foot. That's an impact injury. Heat, moisture, posture. Posture is how a person sits. Incontinence is right in the middle because it's on the outside when it's wet, but it's from the inside if a person is incontinent. It's a challenge from within the body. So immobility, meaning a person has a challenge with being able to move. Sensory loss, we talked about, not being able to feel. Age, disease, there are certain diseases that make you more susceptible to skin problems. Body type, that's everything from being too thin to being obese. Poor nutrition, which we'll deal with as well, and infection. And you're going to hear over and over that I mention infection is a result of open skin. That's an open door for bacteria. And then, of course, it is also affected by how well your immune system can fight that bacteria. What is a pressure ulcer? An area of skin broken down because of pressure. Makes sense, right? Pressure ulcers are sometimes called bed sores, and that's because a lot of people who are not able to get out of bed or are not able to turn in bed can develop pressure ulcers. So that if you hear bed sore, that's where that comes from. Right here you see the 4 stages, from 1 up on the top, the red, and then all the way down. The crosscuts show how they can develop over time, and we'll get into this in more detail. So stage 1 is a reddened area on the skin that, when it's pressed, does not turn white. That process of pressing it is called blanching, and trying to help you understand it just in a simple term is if you have good blood flow to an area and it's kind of red, and then you press it and it turns white, it just means that's what's happening. There's still good blood flow to the area. As soon as you take your finger off, it should turn red again, and that's a good thing. But in stage 1, if you press on it, it still stays red, and that means it's damage. In stage 1, however, the body is still protected, the skin is still intact, and I want to promote again that if skin checks are done every day, a red area can be found before it progresses to stage 2. Here we are, stage 2, you can see the cutaway as it's going down below the skin, or what it looks like if you look at skin. Skin blisters or forms an open sore. The area around the sore may be red and irritated. When the skin's open, the welcome mat is out for bacteria to enter. If the skin is blistered, then do not open the blister. It's something about human beings that we have the tendency to pick or poke something that doesn't look the way it should. But if you open a blister, you're now opening the door for the bacteria. So instead of opening a blister, cover it with a Band-Aid or other dressing just to protect it. And then the body will absorb it over time, and you'll have prevented infection. Stage 3, as you can see, we're looking at the cross-section. We're getting down lower into the different layers of tissue. There's damage to the tissue below the skin. Obviously, maybe, the deeper the pressure ulcer, the greater the potential for infection, and the longer it will take to heal. Another thing that might not be so obvious to you is that a deeper wound can heal over the surface without having healed from the inside to the outside. And that can give a caregiver a false sense of, oh, it's all better. Unfortunately, there still may be bacteria in there, and it will develop into infection. So it needs to be kept clean, gently cleaned, and there's different kinds of things that need to be done. By this time, you may well need extra help with a nurse involved to get this healing done from the inside to the outside. It fills in gradually. Fancy term is granulation. You don't have to know that. That's just a nurse speak term in case you hear it. Stage 4. The pressure ulcer has now become so deep, there is damage to muscle, bone, sometimes tendons and joints. If it's down to the bone, this causes a very high danger of an infection in the bone. The medical term for this is osteomyelitis. And once infection is in the bone, it is extremely difficult to get rid of it. It typically requires weeks of very strong antibiotics. In some cases, amputation of the infected bone area is required to eliminate further risk of infection to other parts of the body. I'm going to start using examples of people I've known who've had some of these problems as we go along. Please understand their identities have been disguised, and I would never share anything that could be a HIPAA violation. So we'll talk about Betty, a person with diabetes who, before she had more assistance, lived independently, chain smoked, totally disregarded her diabetes, so had many years of high blood sugars. By the time she was involved with me, she had already done a lot of damage to her circulatory system. Over time, she has now lost 4 toes and 1/3 of one of her feet because of the osteomyelitis that has developed off and on over time, in spite of now quite a bit of support and close monitoring. Unstageable pressure ulcer. This one is really important for you and anybody else who you know that is working with someone who may have developed a pressure ulcer. The tendency is, if you see what may be thought of as a scab or a hardened tissue, sometimes people think that should be removed. Never, never, never remove this hardened tissue. As you can see in this case, that hardened tissue is covering a deep wound. And if you picked it off, that would be a very negative thing. So it's called eschar. Again, I'm throwing out a few terms here, not because you have to memorize them, but just in case you hear them. What needs to be done is to treat that top gently, coat it with Vaseline, or petroleum jelly is the other word for it, and a dressing, and then it should be assessed by a healthcare professional. We talked about risk areas. So for pressure ulcers, here are the risk areas. What do you see in common for all these risk areas? They're bony areas. I would include, we kind of show the back of the head and the ears, particularly the ears, behind the ears. If a person has oxygen and they have the tubing behind the ears and then to the nose, it's called a nasal cannula, because that rubbing back there can make a pressure ulcer. Basically, any bony area that has little or no fat padding between the skin and the bone are the most vulnerable. That skin gets sandwiched between pressure externally and the bone internally. Risk factors for pressure ulcers include using a wheelchair or staying in bed for a long time, and the inability to move certain parts of the body without help because of those injuries. Risk rises with sustained pressure. Think about yourself right now. I assume you're sitting down, but you reposition yourself automatically as you feel uncomfortable, or you stand and you walk to get something or do something. Every time you move, even a little, you lessen the pressure in one area and move it to another. If you were forced to sit exactly in one position without moving in a hard wooden chair for an hour, you would feel discomfort where that pressure is. If you increase that time, eventually you would have pain there and probably begin to develop a stage 1 pressure ulcer if you sit there long enough. So prevention, changing position frequently to relieve pressure. But what does changing position mean? Frequently in a hospital is every 2 hours. Practically in the home, finding ways to make it happen as often as staffing allows. Items that can help reduce pressure include pillows, sheepskin, foam padding, specialty mattresses, and wheelchairs as ordered by the doctor. And I want to promote the fact that if a person returns home, we want them to return home even if they can't be turned every 2 hours, then that's probably really important to be looking at what needs to be done as far as a specialty mattress. And for sure, the specialty cushions. There are a lot of options available. Of course, they all come with a price tag. Other risk factors for pressure ulcers include a poor appetite, difficulty chewing, assistance required with food and drink. Why is that a risk factor? Well, human nature. When assistance is required with food and drink, the caregiver may become impatient and a person may not eat as much because there's less time allowed for it. Also, the person who is getting fed may become impatient with the process because they're dependent on another person. Lack of thirst is a big issue. Food and fluids are very important to maintain healthy skin. And we need that. We need the vitamins, the minerals, the protein to keep the skin healthy. Later, when we talk about healing, we'll talk about more about nutrition. Without enough fluids, the skin and the mucous membranes become drier and less healthy. If they're less healthy, they're more vulnerable. So what do? We prevent those issues by monitoring clients' food intake and ensure they're eating well-balanced meals with enough calories to keep them healthy. Notice proteins and the fruits and vegetables. Often these foods take effort to find a way for those who have difficulty chewing to be able to get them and enough of them. So first, find out what a person likes to eat. Then find out how to present it in a way that a person can safely eat it. Myrtle, 72, had fragile skin from aging, She wasn't eating well and she was losing weight, and she was at risk for pressure ulcers. So when they came to me, I went out and talked with the staff and the little bit that she would share, and determined she did not like eating meat, and she found it difficult to chew because she was missing teeth, and she also had a hard time if there was anything hard to swallow. So she would refuse. She would refuse meals. But we did know the things she liked, and I encouraged staff that at her age and with her health issues, it was much more important for her to have the things she liked than to have a standard Thanksgiving type meal, which was what they were trying to get her to eat. So she liked smooth, soft foods, she liked sweet drinks, and we recognized and gave her what she needed within those categories, like cottage cheese and pureed fruit, smoothies, pudding, applesauce. And her weight stabilized and her skin did not break down. What else? If adequate nutrition cannot be obtained through foods, offer supplements such as Boost and Ensure. And that is also what we did for Myrtle. She began having 2 Ensures daily, always vanilla. She did not like chocolate, as snacks between meals. So we still wanted to make sure she was sitting down for a meal, but the snack she could have, and that helped her to have extra fluid as well. Monitor clients' fluid intake. That means measure. The goal should be 8 to 10 cups every day. I want to mention Jim. Jim's caregivers assured me that he drank a lot of water daily. And I said, how did they know? And they said, well, he has a water bottle and he's got his mouth on that straw many times an hour. But when I asked them to pour out and measure what was left in the water bottle at the end of the day, they found he'd only drunk half a cup. That's 4 ounces of water from the 20-ounce water bottle. So he was putting his mouth on the straw, but he wasn't drinking. We can be fooled by what we see without actually measuring. Another risk factor for pressure ulcers are contractures. Contractures, as you can see, are when parts, in this case, the fingers, are no longer straight and they're pressing in. We would hope contractures don't happen, but with the understanding they can happen, we need to deal with it. So prevention is to incorporate exercises into everyday activities. To prevent contractures, use range of motion. Have the client do range of motion if they're able, and if they're not, offer to do it with them. And it's simple, gentle movement and straightening of limbs and fingers. And you see an example here. Then check the hands and feet if a person has contractures for pressure within them. And keep the nails clipped to prevent them cutting into the skin. I knew a young man named Paul who lived with his parents. And over time, before he had more support, his fingers had tightly contracted into fists with reddened areas in his palms. His family hadn't understood what to do to prevent it because of lack of education about it. And he now had multiple risk factors from the moisture inside his hands, from the decreased access to cleanliness, and from long fingernails. But after teaching, Paul's family began to clean within the contractures by cleaning and drying with a thin cloth that was slipped between the contracted fingers. They also began to clip his fingernails weekly and smooth the edges with a nail file. And also a small carrot-shaped orthotic was slipped into his hands to help open his contractures as much as possible twice daily. The family took turns gently stretching his fingers even just a little bit away from the skin. And though it was very limited, it was helpful too. And over time, they were successful in preventing that redness and also preventing stage 2 open pressure ulcers. Risk factor for pressure ulcers, I've mentioned briefly before, as you can see on this, incontinence of urine or feces, that's BM, can lead to skin breakdown very quickly. I like that. Please hold, if only. We wish that was possible, that people could not be incontinent, but some individuals will always be incontinent because of their disabilities. Others develop incontinence because they're on medications such as diuretics that cause increased urgency and frequency of urination. Others become incontinent over time from other illnesses, diagnoses, or from dementia. How do we prevent pressure ulcers from incontinence? Well, of course, the key is to try to prevent that wetness on the skin. So often people haven't thought about that they could try a toileting schedule. I encourage, as just a basic, is 2 hours apart typically. However, if persons have diuretics that they're taking, it may be an hour. Every hour they need to be taken to the bathroom. If they're regularly incontinent, then they need to have an incontinence schedule. Check incontinence garments frequently and change as needed. The same thing applies. Check every 2 hours. Or if a person's on a diuretic, it may need to be more often. And usually diuretics are given in the morning, causes them to get rid of fluid. And by afternoon, they may be able to be just checked every 2 hours, but in the morning, every hour. So after they've urinated or had a bowel movement, whether they are continent or incontinent, they need to have the area cleaned and dried well. Always clean from the front to the back. And then use barrier creams or ointments as ordered to help protect the skin from the wetness or the fecal contamination. I had a client, still do actually, Shirley, and she had a history of UTIs, that's urinary tract infections, and skin breakdown in her perineal area. There was concern about not waking her up or not taking the time during the night to check her for wetness. But after these recurrent problems and hospitalizations, the home staff decided it was necessary, and they began to change her twice a night. And it worked. Her skin healed and her UTI recurrences stopped. We all decided it was worth it. Risk factor for pressure ulcers are certain diseases, but specifically diabetes or vascular disease. As I'd mentioned, the need for good circulation. Well, diabetes can cause poor circulation in the feet, making ulcers more likely to form when the skin is damaged, and it makes the ulcers slower to heal. Here you have a picture, and well, you'll get to see some more pictures too. I want you to understand the dangers, and so some of the pictures might be a little gross. Here's an explanation. With diabetes mellitus, which is what you commonly are thinking of when people have diabetes, stage 1 or stage 2, there is excess glucose or sugar particles circulating through the bloodstream. You can see those little white particles in this diagram. These particles can clog up small blood vessels. We call them capillaries, especially in the fingers and toes. And if they're clogged, no blood's getting through. Remember Betty, the person with diabetes who lost her toes? This is also a good diagram explaining what happens when a person has neuropathy. You can see the blood vessels and you can see the nerve. And as the blood vessels get diseased, they're not providing the nutrition and the oxygen to the nerves. And so then the nerves die away. Clients may lose full sensation to their hands and feet. They may lose complete sensation to their hands and feet, or they can feel discomfort, numbness, burning, tingling, but they're not feeling the pain that they should be feeling when something's wrong. We often think of pain as our enemy, but pain can be our friend when it alerts us to a problem. Have you ever had a small stone get in your shoe? That happened to me yesterday. I had to stop everything, sit down, and get that stone out of my shoe. You quickly feel it. It might be so small you can hardly see it, but you feel it and you stop to get it out. What would happen if you couldn't feel it? Well, skin breakdown from diabetes is what happens. Here we have a picture of pre-ulcerative callus in a diabetic. Calluses can form on the client's feet because of different positioning. They're putting pressure specifically on an area. Maybe the shoe is not fitting exactly right. Calluses and dry skin increase the risk of skin breakdown. Dry skin and thick calluses often cause cracks in the skin. So just a thin line opening, and that's an open door for bacteria. Feet in general are very vulnerable to infection. So loss of feeling puts clients at higher risk for injuries. Here you see a little spot where something punctured the sole of the foot. No pain is felt from stepping on sharp or objects or getting blisters from poorly fitted shoes. In a previous job in the community as a nurse, I worked with a woman. I'll call her Lily. She had diabetes and she had neuropathy. Even though she had normal cognitive function, she was at risk. She lived with her husband, and I had warned her because she loved to walk barefooted. I told her this was very dangerous when she did not have feeling in her feet. So one Monday morning, I got to work and I had a call from her family, and they said she was in ICU in critical condition. She had gone to the ER Sunday evening. Her whole body was infected. That's called sepsis. Her kidneys had shut down. And what they found when she went to the ER was a piece of glass in her heel. Friday night, a glass had broken in her kitchen. Everyone thought they'd gotten it cleaned up, but there was a sneaky piece of glass, and she didn't even realize it was in there. She didn't feel it. She walked on it for 2 days. So she had a very long recovery. She did survive, but she was never exactly the same afterward. Whenever you've had your kidneys shut down, they can start working again, but they're more at risk. And it took a long time. It took months for that wound to heal. Here's another picture that might not please you, but you need to know what it is. This is gangrene. A foot ulcer, once it forms, easily becomes infected. And with neuropathy, people may not feel pain from an infection until it becomes serious and difficult to treat. And if you don't have blood flow, it can lead to gangrene. If you ever see a body part this color, get the person to the ER right away, please. I had a call from a caregiver one afternoon because Sally had called her and said, "My foot doesn't look right. I took my shoe off after I got home." And fortunately, I was able to get there within an hour, and I saw one toe that looked just like this. And I counseled getting a call in to 911. She had to go by ambulance to the ER right away, and they amputated that toe that evening. People with diabetes are more than 30 times more likely to require amputation of a foot or leg than are people without diabetes. You see the one with the toes amputated, and the other with an amputation or up to the knee. Think about this. This person with the toes amputated now has more pressure to the rest of the foot. And that's one of the problems. Our toes are more useful than we realize. They help us spread the pressure and they help us walk normally. When those are gone, even though an orthotic is put in the shoe to kind of fill the place, the pressure is more specifically to what's left. And the more pressure you have on your foot, the more chance for more pressure ulcers and the more chance for infection, and around we go. And that is why for some people, bit by bit, they lose different parts of their toes and feet by amputation. So prevention. We have a lovely list here to prevent diabetes complications. Control blood sugars with meds, eat healthier, lose weight, exercise, quit smoking, and reduce stress. Wow, simple instructions, but major life changes that are difficult to complete. I just want to encourage all of you, whether it's for yourself or for people with whom you are working and caregiving, to be patient. Work on small changes over time in each of these areas. Getting the right meds might be the first thing. Doing whatever you can to get them to quit smoking is would be a huge help. And gradually working on changing what's being eaten and exercise. Exercise might be just walking up and down the hall once a day. So we need to factor in changes, should be gradual if they're going to be effective and long-term. Prevention again, do not let clients go barefoot. This might be an easier one to implement if you are making sure that they have something to wear that's comfortable. Check the feet daily. You can share the story of Lily and the glass in her heel if you need to, because going barefoot almost killed her. Remember, no, I haven't shared before, so I will share this and you'll hear it again. No lotion between the toes. You see that capital letters, not between the toes. We do want to provide lotion, but if you have it between the toes, you're setting up a possible fungal infection because then there's moisture between the toes. So we'll go into that more daily. Shoes should fit properly and have cushioning. So another thing that I do is I take a nylon knee high, put it on my hand, and go rubbing in all through and around in the shoe. If that nylon snags anywhere, I know there's a rough spot in the shoe. So besides proper fit, we want to make sure there's cushioning and we want to make sure there's no rough spots in the shoe. Diabetics and others who have neuropathy or no sensation in their feet should see a podiatrist to have toenails cut and calluses removed. Why would that be? Well, have you ever used a nail clipper and you just nicked the edge of the toe when you cut the toenail? It's really easy to do, but just a small cut in the foot is an open door for infection. What happens? What do we do about any pressure ulcer? The very top one should probably be in capitals and neon, if I could. Determine the pressure causing the sore. Okay, that is up to you. If you are a caregiver, or if, and by caregiver, I mean family member as well, your key as a detective in figuring out what is causing the pressure. Stopping the pressure is needed to allow healing and to keep it from recurring. No matter how excellent wound care treatment, the pressure source is not eliminated, the person will either not heal or they'll get another one. Every place where there's been a pressure ulcer and it's healed is more vulnerable because that skin is never quite the same as the original skin. If the pressure ulcer is an open sore, a doctor or NP should order required wound care. We have a couple of slides here that talk about nutrition and wound healing. That's also important. We talked about nutrition to prevent wounds, but what if the person has wounds now? Now what do we do? Is there anything we need to pay attention to as far as nutrition? And certainly there is. You see on this slide the key players, vitamin C, A, and zinc. There's a list of how you can obtain those in your food sources. And there's also recommendations of possible supplementation. So a person might need a boost or ensure or another special kind of supplement to drink, or they might need extra zinc or vitamins in a supplement of a pill. But we don't want to forget that we need to have the materials to help healing. Among that list, so I often tell people, look at what a person will eat and can eat. So you look at these, for instance, vitamin C. I like oranges, strawberries, broccoli, and peppers, and I despise cantaloupe. Just saying. So if you have a person who doesn't like a food, don't push it and promote it and say, this is what you have to eat. Try to find something from that list that a person does like and can eat. This is more about the nutrition piece, talking about the in general in the first two columns, but mentioning protein specifically in the third column on the right. And I want to really focus on that because when a person has wounds, it is super important to have enough protein. Those are the building blocks, along with the nutrients mentioned previously, in getting a wound to heal. And if a person is not getting protein, that's going to very much slow down the possibility of the healing. So again, from that list, find things that a person can eat. And again, the fluids, we've talked about fluids to maintain good health in the skin. We need the fluids for healing as well. Okay, let's switch from pressure ulcers to something called yeast. You might know yeast as a component of bread baking. That's a good yeast. We're glad to see yeast when we want to bake bread. But yeast on a human skin is not something any of us would desire. It's a fungal infection. The fancy name for yeast is candidiasis, or also called Candida albicans. So when skin is warm and moist, the conditions are perfect for yeast, the common skin fold rash. And the areas most affected, if you're going to be sure and look for these, are under the breasts, under the stomach, in the armpits, and the groin, and skin folds. Just skin folds if you have the saggies. If you're older, that's what saggy does. And skin folds if you're obese. The heavier a person is, the more likely they're going to have deep skin folds. So risk factors: moisture from sweat. I have a number of people that I work with who do pretty well until summer comes, and then they sweat a lot more, and then yeast becomes much more of a problem. The rubbing together of folded skin and the irritation caused by normal skin germs, which thrive in this environment. Callie, another client that I would have worked with, was obese, and she was in her 60s. She was a very private person. She had been more independent in her past, and she didn't want anyone to help her with her showers. And she spent most of her day sitting in her easy chair. She was verbal, but she was too embarrassed to share what she was feeling: pain and discomfort in her skin folds from the yeast rash that had developed. But eventually it got so bad that it opened and it was dripping blood on her panties and on her clothes. And at that point, she had to let people know, and she complained about it, and she needed help. And it was so bad, she needed an oral medication, a pill that she had to take for it, to go from the inside out, as well as, guess what, assistance with her hygiene, a medicated ointment, and a wound dressing that would fit in and along the skin folds. And she had to have help twice a day. Once it healed, she then was willing for assistance with her twice daily hygiene. Then she was able to use a medicated powder within the skin folds to keep the yeast from recurring. So prevention, as we just said, wash the skin folds. Wash them gently with soap. Can't emphasize enough, gentle is best. Don't scrub. Also, check the washcloth you're using. Is it old or was it cheap in the first place? Feel it. It's maybe very rough because that often happens. We don't want rough fabric. We want fabric that is smooth and soft. Gently may not be too hard if you're taking the time to clean somebody's skin, but where I find that's challenging is if it's in the perineal area and there's been BM, incontinent BM, and now you've got dried fecal material on the skin there. And people are saying, how can I wash gently? I got to get that off of there. So I encourage you to wet it first. Using a cheap little spray bottle with water in it that a person can have in their backpack and even have this help wherever they are in the daytime, or using the shower spray. Spray it first, let the shower do some of the work, and then once it's wet, then you're more able to get it washed gently. Rinse well too, that's very important, and then pat the skin dry. Again, don't rub and scrub. Use a blow dryer if you need to dry skin folds completely. You'll want to use it on a cooler setting, but make sure that the skin folds are completely dry. Then apply a thin layer of powder to the skin folds, smoothing out across the skin. Do not, there's another capital not, shake a lot of powder into the skin fold. It can cause a thick paste to form, and that it can irritate the skin. I had a client named Sam, and his team complained to me because I had given them information, except that I just said use powder. And they said, the powder isn't helping, it's making it worse. So I went out and looked, and sure enough, it was worse. But they were shaking a lot of powder in there, and it had formed a roll of thick powder paste in there that then rubbed against the rash, and that made it raw. So always when you use powder, gently clean, gently dry, and then smooth powder across the skin. What else can you do? Wear loose, breathable clothing. Make sure that the clothing is a fabric that isn't synthetic or isn't too thick to allow sweat to air dry. Avoid double depends because that prevents air from getting in there, and that can lead to yeast as well. Stay cool to decrease sweating. That can be a challenge, but if a person has a fan to blow on them when they're in the home, and if they have air conditioning, they need to use it. Leroy had developed a red rash in the crack between his buttocks, and it was up a little bit higher. He wore underwear, and he wasn't incontinent, so I didn't think it was from urine. But the team asked me to come out and check. And when I checked, what I found is that he had gained weight, but his underwear and pants were way too tight. And this caused him to have both increased sweating in the crack as well as rubbing because his clothes were too small. So the key was staff went out and bought the correct size, and then he had powder smoothed into the crack, and the redness disappeared. Got to emphasize, it is necessary to treat. It is painful, and it can cause open sores if left untreated. And I've had this happen where bacteria entered those open sores and there was cellulitis. And I didn't hear about it until the cellulitis part, and the person was hospitalized for cellulitis. The unfortunate thing when you have cellulitis, which is an infection, then the person has to have antibiotics. And when a person has antibiotics, that kills your good bacteria, which then allows more yeast to flourish. So it worsens the risk for increased yeast. We don't want to get to the point where there's an infection. What can we do? Treatment. Have the skin assessed by an MP or MD. Then obtain an order for medicated antifungal powder or ointment from the doctor to apply twice daily after cleansing and drying the skin. So on the left, you see a nystatin cream. On the center, a nystatin powder. On the right, a ketoconazole cream. I did deliberately choose those pictures. The nystatin powder is typically step one. If someone has a little redness and pinkness in areas, the nystatin powder can be ordered, and then it can be as a PRN, as we've talked about before, if a person has nystatin powder on hand and applied as needed when it recurs. Nystatin cream's a bit stronger. I've actually had a few doctors recommend the cream with the powder. But in general, the cream you want to use if it's worse. If that isn't enough, the ketoconazole cream is usually the end product. It's much stronger. We do not encourage long-term use of the ketoconazole cream because it can thin the skin over time. People can use powder as a preventive, so they don't have to have an order. You can buy powder in just about any store like Walmart or a drugstore. I often recommend powders that you might see that do not have any kind of scent in them. But what's most important is that you don't have cornstarch in them. Yeast likes cornstarch. It likes to feed on it, and then it thrives more. So you want to look at ingredients of any powder that you might use to make sure that there's no cornstarch in it. And like I said, unscented may be best in case there's any response or reaction to scent or perfume, whatever you want to call it. Sometimes people have that problem for an allergy. I often recommend Gold Bond medicated powder just because I know that that can be a good one, but certainly there are other powders that work as well. Oh, I do want to mention one other thing, almost forgot. Sometimes I go into a house because people are saying there's a skin issue, and I see multitudes of different kinds of creams, and people don't know. They don't know which one they're supposed to use. Here are all these tubes of creams just sitting there, and they may have just used any cream because it ought to help, right? But it doesn't. It can make yeast worse if you use the wrong one. So it is very important. And some of those creams, if I look on the date, they've been there for years, just kind of sitting there, and they're not really very decorative. So if a person has more than one cream for more than one problem, please make sure that's clearly labeled what it's for and when. And then if a person has, I would encourage putting them away, frankly, in a drawer or a box or something. Whatever issue the person has, so now it's needed. The person maybe needs nystatin cream. You need to get that out, leave that one out, leave the rest put away so there's no mistakes. Athlete's foot, another kind of fungal infection. And guess what? It's between the toes. And it is contagious. And it's why I said don't put lotion between the toes. Also, be careful about direct contact or sharing shoes. If a person has it right there between those two toes and somebody else wears their flip-flops, guess what? They get to share. So be very careful about sharing shoes or using, people classically, if they are in a locker room or they're near a pool, they can pick it up from somebody else. So what's the prevention? Well, clean between each of the toes with a soapy washcloth, rinse well, dry completely. That's so we keep the condition there, not hospitable to fungus, right? I recently heard a podiatrist, a foot doctor, say, floss between the toes. And I like that term, of course, with a washcloth, not with dental floss. to make sure you get clean between the toes. And then avoid sharing shoes, as we talked about, and do not walk barefoot in areas such as locker rooms or in a shared bathroom. How many people walk barefooted into the bathroom? They may share with family or with another resident in a residential setting. And if you do that and somebody else has a fungal infection, you may share it. Treatment. Have the feet assessed by an NP or an MD. Apply antifungal skin medications as ordered. If you are a family and you're suspicious of it with a family member, you can get a powder over the counter and try it and see if it helps. If you're in a residential setting, a client must have orders, even if it's over the counter. If it's really bad, they may have oral medications that must be ordered by the doctor. And as we talked about, keep feet and the inside of shoes clean and dry. I have had a household remedy recommended, and I think I've had a few people use it. I'm not certainly promoting it, but I don't think it would do any harm. It's vinegar, 1 cup, to water, 1 cup. So you use equal amounts of vinegar and water for a foot soak. I do, however, want to remind you that if you have a foot soak, you must dry carefully or it's going to undo what you did. So foot soaks are okay, but make sure the foot is dry between the toes as well as top and bottom after that soak. Skin shearing may not be something you're as familiar with. This is something that nurses get taught. It's a little bit challenging to maybe think about, and I hope you can see from this slide, but it's basically when the skin sticks to a surface while the muscles slide in the direction the body is moving. And maybe it'll make more sense to you when we get to the next slide, especially looking at this person in the circles. So if a person is sitting in a chair and then they slip forward, they slouch down, that is a common risk for shearing because the skin may want to just stay put where it was, but the rest of the body is going down and that causes that shearing. So make sure a client is securely sitting in an upright position, and there are ways to keep the person in the upright position. For some people, that's a belt to hold the person in position. There also might be something called a reverse wedge cushion, which is thicker in the front, and they kind of put that on the seat, kind of helps keep the person from slipping down. There's different ways, but the main thing is to try to prevent a person from slipping and slouching. Do not try to lift a client by tugging or pulling into a new position. Here is a very good picture of a shearing injury. And then it shows 2 people using a slide sheet to help a person to be repositioned. Here's another example of using a draw sheet and helping a person have their arms together and their knees bent, so you get them in a position to help them move as easily as possible to prevent the shearing. And the people who are using good body posture themselves to help the person move up. I know sometimes it's difficult if you don't have 2 caregivers, but try to plan to have 2 caregivers if possible when you are repositioning somebody to prevent the risk of shearing. Also use gravity to help you. So if there's a hospital bed, you can make sure that it's flat, or the head of the bed, if it'll go down a little bit, that will help. If a person's in a wheelchair and they have a reclined position, be sure and use that to help. And if a person is being transferred with a Hoyer lift, make sure while you've got the Hoyer on there that the person is correctly positioned all the way to the back of a chair. Skin tears you may be more familiar with. Skin tears are somewhat similar to shearing, but they happen not on your backside or your back, your bottom, but on your extremities. So here we see one on a hand. They're traumatic wounds, and they're showing the top part of your skin, the epidermis, separating or tearing from the next layer of your skin, the dermis. You may be familiar with pulling a hangnail off along the edge of your fingernail. That's a skin tear. So you want to be watching for these. They can happen, unfortunately, very quickly. Risk factors: corticosteroids. Remember the ketoconazole cream that I mentioned? That's a corticosteroid, and used for an extended period of time can thin the skin. Advanced age, very common. The older we get, the thinner our skin gets. Immobility, being bedbound, chairbound, or unable to change positions. If skin sticks in one place for a long time, like say your skin sticks to vinyl on a hot day, you might have experienced that. And you can kind of feel that as it comes loose. Well, if you have a thin, fragile skin, that epidermis, that external layer is going to come free. The biggest risk factor that I see is adhesive. Tape from dressings, adhesive from incontinence products tabs, and we'll talk about how to prevent that. Dry skin and dehydration, of course, that makes sense, right? Makes the skin more vulnerable. Inadequate nutritional intake, we've talked about that before too. And multiple medications and multiple disease processes that cause fragile skin as a risk factor. So one of the things that I have seen is with a person that I'll call Hester. Her team called me and they were worried. I was so glad when they called me, first of all, because communication is key. They found a shallow red open spot in her perineal area. So when I went out there, I saw it was a skin tear. She had been wearing a pad, an incontinence pad, within her Depends, and they had covered adhesive tabs, which they didn't use, so they just didn't pay attention to them. But what had happened is that covered tab, the cover had come off, and the adhesive had then stuck to her skin. When they were going to change her, they quickly pulled it out and took the skin off with the adhesive tab. Once we figured it out, it was relatively easy to repair the damage because it was found almost immediately. We covered that open spot with Vaseline. That works well as a dressing cover for a shallow wound. And then all the staff were told that they had to cut the tabs off on the pads before they put them in her Depends. And now there wasn't the risk, and the spot quickly healed. So prevention. Secure dressings with gauze wraps or stockinettes. Here you see a stockinette, if possible, so we're not using tape. Avoid tape if you can, and if you must use tape, use paper tape. Also, when you take tape off, take the time to wet the tape first. You can use that little spray bottle of water I recommended earlier, or just take a paper towel that's wet and just get the tape wet. And then slowly roll the tape off. Don't rip off the tape, which is much faster, but the skin can come with it. If you can secure dressing on an arm, leg, or foot by wrapping gauze around the limb and then using tape on the gauze rather than on the skin, that also can prevent any risk of damage. Sometimes people have skin tears just from coming in contact with things, such as this shin bone finding furniture. So wearing long sleeve shirts and pants to protect extremities can be helpful. It can be helpful when a person is in a wheelchair, for instance. And keeping pathways clear in the residence. That can really be helpful to prevent coming in contact, and having a night light is also helpful. So we want to make it safe. Exercise caution, we've kind of referred to this already, during bathing, dressing, transferring, and then padding, bed rails, and wheelchair arm and leg supports. Apply a moisturizer. We've talked before a little bit about moisturizers. Apply a moisturizer, especially on dry skin, on arms and legs, twice daily. I have some of my favorites up there. I would also add Aquaphor as another good one. Trying to prevent things that have too much scent or too watery. So those really can do a good job. Adequate nutrition and fluid intake. Obtain a dietary consultation if needed. We've talked quite a bit about nutrition already. I can't emphasize enough, nutrition and hydration, very important for healthy skin. Treatment. Determine the cause to stop it from happening again. Gently, you've heard me already about this, gently clean that open area and pat dry. Cover with Vaseline or antibiotic ointment. I've gone with clients multiple times to wound care appointments, and at first it kind of surprised me, but it often is recommended to use Vaseline, also called petroleum jelly, to cover a wound, and it can be reapplied as needed, and then we aren't causing a problem for that thin skin with tape. Cover with a dressing only if it can be secured without adhesive. See an MD or NP if wound care orders are required. Rashes. Rashes may be caused by an allergic response to soaps or other irritants. That's called contact dermatitis, by the way. So if you take someone in to a doctor and that doctor says, oh, Joe has contact dermatitis, don't be too thrilled. He's just giving an explanation of what's happened, and that doesn't do anything except tell you you've got to find the culprit. Rashes can also develop from being overheated. That's a classic picture there of a heat rash on that person's back. And rashes may hurt or be itchy, as you can see there. So I'm wondering, most people have had an itch. Have you ever had an itch? Maybe you had poison ivy or a mosquito bite. Itching is a very strong sensation, very difficult to ignore, the need to scratch. So be aware of how challenging this is. Don't expect that telling a person, don't scratch, is going to work. I got to own up to my own scratching. My children were prone to getting out into things called poison ivy, and guess what I said? Don't scratch. And then I got poison ivy. And then I had 4 kids saying, Mom, don't scratch. Because without me even realizing it, what was I doing? Scratching. So, prevention. Be aware of known allergies and avoid them. Boy, do I avoid poison ivy. Rinse clothes fully to remove soap residue. I bring that up because it's so easy as a caregiver to be in a hurry, to be frustrated. You've got wet sheets again, and you've got wet clothes, and you put them all into the washing machine, and maybe it's extra full, but you can get them all done in one load, and that's all the time you want to take. And then the soap doesn't get fully rinsed out because it's too full of a load. And if there's soap residue in clothes and it's against the skin, now you've got a perfect chance for contact dermatitis and a rash. Also, monitor for rashes. No surprise here. What did I say? Skin checks, skin checks. If a rash is found, use your detective work. What's changed? New clothes, new detergent, new deodorant, new medication, exposure to poison ivy or bugs. What do we do about it? First, wash and rinse the area of the rash with cool water to remove anything causing the rash. Then apply medications as ordered if needed, or over the counter if you're a family and you have something that you can give, such as what do we have here? Calamine lotion on the right and cortisone cream on the left. Um, Otherwise, if you have to have an order, make sure you have a PRN for rashes. Keep fingernails trimmed and cover the rash to prevent scratching. Well, here are some boils. Have you ever had a boil? Or a folliculitis, or a skin abscess, or a furuncle, or a carbuncle? They're all boils. A boil can develop as an infection of a hair follicle, which you see down on the right, and you see the example of what happens. A boil can be caused by a plugged pore that gets infected, which is what we have on the left. How do you prevent boils? Keep the skin clean and dry. So to let a lot of moisture develop. If a person has a history of boils, use an antibacterial soap, such as Hibiclens, and avoid wearing constrictive clothing that can cause ingrown hairs and excess sweating. Another common cause of ingrown hairs causing a folliculitis, a boil, is shaving. So be on the lookout for risk factors. What do you do about a boil? It does take some patience, but hot, moist compresses. So I'm talking about hot water from the sink, not hot enough to cause a burn by any means, on a washcloth, then squeezed out and placed on the boil. Over time, heat helps the boil to develop a head, and when the boil bursts, pain relief occurs. A large boil may need to be lanced, meaning cut open, to get the head to come out by a doctor or an NP, not by you. Some skin abscesses are caused by staph infections, and so some may be caused by MRSA, which is methicillin-resistant Staphylococcus aureus. MRSA is contagious and it can be dangerous. So if a person's ever had MRSA and they get another boil, they need to have a culture done to see if it's MRSA. Always use precautions, as you should be doing. And try to be very careful around that boil. Watch for cellulitis as well, because if it becomes red, hot, and swollen way beyond the boil, that means a possible cellulitis, and that needs to be seen by a doctor for antibiotics. Here's cellulitis. So cellulitis, what do you see? Hot, red. Sometimes there's something coming out of it, but sometimes there isn't. And so if this develops and there's swelling, a lot of times there's swelling as well, it does need to require a doctor's appointment. And if you can't get to the doctor within 24 hours, maybe at most 36 hours, go to urgent care, go to an ER. Because it can develop rapidly and it can worsen quickly. You're going to have antibiotics to take care of it by mouth or by IV. People can die from untreated cellulitis because it can take your whole body into an infection state called sepsis. And so you really do want to take this very seriously. Self-injury and picking. When I did the research before I developed this webinar, I had in my mind that it was most typical and maybe only typical for people with IDD. To my surprise, I found that there are many people who do pick and scratch. They're kind of careful to keep it under wraps. In other words, cover it with clothing. So it is a common problem. It can cause repeated injury and open sores. So what can we do about it? One, keep client busy with activities using the hands to prevent them from doing the picking. If picking worsens, monitor for increased stress or pain or itchiness, I will add, neuropathy. Be aware of and treat for insomnia. Insomnia means not being able to sleep at night because picking often is worse at night. Roberta is a young woman with limited language, and she was known to be quick to pick. This had been the case since she was a child, and it worsened as she became a teen. And while staff and family were concerned, they wondered why I made such a big deal about it. But then she got a cellulitis and ended up in the hospital with IV treatment, and it was very difficult for her. So at that point, staff and family became much more careful and cautious. And they developed a plan to minimize her opportunities to pick. Keeping fingernails short and smooth is obviously an important one. Putting gloves or socks on hands at night if a client will allow, because it's so easy to pick when you're half asleep or maybe even in your sleep. I did have one young man that he wanted gloves on, and he wore them until he was picking behind his ears. Once he wore gloves, it gave him those areas a chance to heal. Roberta absolutely would not wear gloves or socks on her hands at night or at any time, actually. But what worked for her is having compression sleeves on her arms and legs, and then having clothes over that. But there was still an issue, because when her clothes were removed, when her pants were down, when she was going to go to the bathroom, she would be quick to pick the minute staff weren't watching her. If they watched closely and distracted her or cued her with Roberta, no, she would stop. So this has been a really long ongoing issue, and every staff has to learn how quick to pick she is. What's the treatment? Antibiotic ointment on open areas as needed, dressings on open areas if required, wound care orders if needed. Oral medication is sometimes necessary if we know that people have OCD, which is obsessive compulsive disorder, and the picking is a part of that, or when they're anxious, they pick, or if they have dysregulation from too much stimulus and they begin to pick. It may be that medication for mood regulation or skin sensitivity can be helpful. So there are a multitude of psych meds. Also gabapentin and Lyrica I will mention, because I have seen that can be very helpful. Its main use is for neuropathy, but it can be very helpful for people who skin pick. All right, let's review. What do you watch for and what do you report? Discoloration. I give a whole long list of colors here, but I do want to reference that if somebody has had a skin problem in the past and it's healed, especially if they're over 50, there may be a permanent discoloration in that area. It's kind of an aspect of scarring. In fact, Roberta, that we talked about, who's still a very young woman, she has a discoloration on her shin because that had been her quick to pick area over and over again. And even though it's healed, it's discolored. So it is important that, you know, that skin map we talked about, that you mark on there that there's a permanent discoloration from past injury, so that people don't freak out, don't worry that there is something new happening. So beyond color, you may see a blister, a pimple, a bruise, a skin feeling warmer than surrounding skin. I recommend taking the back of your hand with a glove on and feeling the area, and then feeling the area right around the area of concern, because if it's considerably warmer than other areas, that is something you need to note. Breaks in the skin, tears, scratches, scrapes. I didn't say cracks, but we talked about cracks too. All need to be noted. Now we're going to talk about a few people and see if you can figure out, based on their description, what their issue is. So here you have Mario. He's thin. He can't move his body below the waist, decreased feeling, sits in his chair all day long, doesn't want to use the recline, sits upright with the head of the bed up at night, and watches TV till the wee hours of the morning. In addition, he's sometimes incontinent, not always, of BM or urine. What do you think his health problem, his skin problem has been? Well, if you said pressure ulcers, you are right on. All of those things, being unable to move, not feeling, wanting to sit upright on the same area, his bottom, and also the incontinence, all gave him high risk for pressure ulcers, and indeed that's what he had. So what could we do to help him? Well, for one, he's thin, and that makes him more at risk for pressure ulcers. So we encourage better nutrition, more good ways to increase calories. Then we also looked at, did he have a good enough chair cushion? And we worked out a plan that he could have a timer. He was afraid of reclining because he thought nobody was going to bring him back up to the upright position. So he agreed that if he had a timer that went off after 5 minutes and the staff then brought him back to the upright position, he was willing to recline. We also made sure he had a pressure changing mattress, alternating pressure mattress, and with the incontinence, a toileting schedule. So all of those helped to heal pressure ulcer and to prevent pressure ulcers. Joe's 75. He has thin, dry skin, which can become itchy at times, especially during the winter when the air is dry in the house. Sometimes he bumps into things and hurts small spots on his shin or arms. He often has times of sleeplessness at night. He has schizophrenia and OCD and hard fingernails that grow rapidly. So, what's his skin problem? You probably figured out. Skin tears and picking, both. What can be done to help him? Well, for one thing, the dry skin. That should jump out at you. He needs to have lotion on his dry skin to prevent itchiness. What about the bumping into things and hurting his shins and arms? Making clear pathways, making sure there's a night light, making sure his arms and legs are covered when he goes to bed. The sleeplessness too. Can we find something mild that will help him sleep at night? Something like melatonin to prevent that sleeplessness. Making sure his schizophrenia and OCD are appropriately treated by a psychiatrist. And now we have the hard fingernails. Oh, it can be very hard to trim fingernails for an older person. So if you can, get him to soak the fingernails, or right after a shower, try to cut the fingernails, get into a routine so you can get those trimmed. One more, Carol. Carol is obese. She's over 300 pounds. She's in her 60s. The combination of that and obesity has resulted in large, deep skin folds. She cannot successfully reach and clean all areas of her body, and she refuses assistance from staff. She gets overheated easily, and she sweats a lot. She has diabetes and poor circulation, and she is occasionally incontinent of urine. So what is her skin problem? What would you guess? Yeast. If you guessed that right, you've looked at these clues. All of these things make her more at risk. One thing I might have not mentioned before is that if you have diabetes, your risk of yeast goes way up. I said that yeast likes to eat cornstarch, but it also loves that sweet sweat that comes out of somebody with diabetes, especially if their blood sugars are not closely kept under control. So, what could we do for Carol and her risks? We can't change that she's in her 60s. There's just no way we can do that. She is the age she is. So what can we do about the other things? Well, we worked on better control of her blood sugars, healthier eating, basically strongly encouraged her to have her skin folds cleaned by someone. She finally agreed. She didn't want them to see her whole body, but she was willing to lie down on a bed. And that's the easiest way to open skin folds. So she was willing to allow staff to wash those skin folds when she was lying on a bed. And only the skin folds, thank you very much. Once a day was all she was willing for, but she was willing to do it a second time a day with wet wipes. And that too is helpful, better than not at all. And then she did agree to go to the bathroom every hour in the morning after a diuretic and every 2 hours in the afternoon or evening. So with that combination and with her willingness to have the powder in her skin folds, we were able to keep that yeast from getting out of control. She still had some pinkness there, but it didn't develop into a crisis situation, and it didn't open up so that she would have an infection. We have these other webinars that will be available on the Win Distance Learning webpage, and we really hope this webinar will help you to focus on skin and keeping it healthy, intact, checking for skin problems, and then looking for clues to help you understand what could be happening and to realize what the next steps should be. Thank you for watching.